My fellow colleagues, my name is Thomas Fraser. I'm the President-elect of WONCA Europe and the GP in Germany. And on behalf of WONCA Europe and on behalf of our President, Professor Shlomo Winker, who is not able to join us today, I'm very happy to greet you and to welcome you for today's webinar, which will be about the practical application of lifestyle medicine and social prescribing in daily clinical practice, in daily general practice and family medicine. A webinar which is obviously hosted by us, by the WONCA Europe family. We have very dedicated speakers here, and we have a very dedicated moderator for today's webinar. It's Lilach Maletsky from Israel. Lilach is very active in the field of lifestyle medicine. She's a very active member of the special interest group of WONCA Europe on lifestyle medicine, has provided many lectures and is also a member of the specific Israeli Society of Lifestyle and Medicine. So, Lilach, the floor for the moderation is yours. I wish all the participants and all the presenters and you as a moderator a very interesting and successful webinar, and we all will meet again, and I will be with you again for the discussion.
Thank you, Thomas, for your lovely introduction, and welcome everybody to the Lifestyle Medicine and Social Prescribing Special Interest Group webinar. It's a joint webinar, and soon you will meet all the presenters. So I'm Lilach Maletsky, and I'm the chair of the Lifestyle Medicine SIG, and I'm happy that so many people found it interesting to join us and to hopefully find practical ideas to take into your clinic. So applying lifestyle medicine in primary care is crucial because lifestyle factors such as nutrition, physical activity, sleep, stress management, and substance use play a significant role in the development and progression of chronic diseases. Our Lifestyle Medicine Special Interest Group mission is to promote evidence-based lifestyle interventions amongst primary care physicians. And we hope that through raising awareness and providing knowledge and tools, you will be able to improve management of chronic diseases and overall health in with your patients. This evening, we will concentrate on two pillars of lifestyle medicine. Dr. Tehila will present about healthy nutrition, and Dr. Muna about smoking cessations. Professor Joyce Kenkre, she is the chair of WONCA Europe Special Interest Group for Social Prescribing and Community Orientation. She will present how to improve healthy relationship. This is also one of the 6 pillars of lifestyle medicine, and this time it will be through social prescribing. Please feel free through the presentations to use the Q&A box. And at the end of all the presentations, all the experts will try to refer to the questions and answer the best they can do. So let's begin with our first presenter, Dr. Tehila Mazal. She is a family medicine specialist and a member of the Israeli Society of Lifestyle Medicine, and also a member of the Lifestyle Medicine Special Interest Group of WONCA Europe. She will present the evidence-based medicine and the use of the Mediterranean diet. So Tehila, please.
Sorry, my computer just restarted itself the moment you started speaking. I apologize. So to share my presentation, are we to start?
Yes. Yes.
Thanks. Sorry, I missed out the last 2 minutes.
The webinar is yours, Tehila.
Do you want maybe Muna to start? I need to open it because my computer shut everything down. Sorry.
Muna, are you ready?
Apologize.
Yes, I will share my screen.
Okay, so just let me present you. We are changing the order so Tehila can restart her computer. So Dr. Muna Sharif, a family physician, certified lifestyle medicine physician from the American Board of Lifestyle Medicine. She works in Dubai, in the UAE, And also she's a member of our Lifestyle Medicine SIG. She will present how to use a motivational interview to support patients to quit smoking. So, Muna, please.
I'm happy today to present at WONCA webinar as Ms. Dr. Lila introduced me. I am Dr. Muna. I will speak about motivational interview and smoking cessation. So motivational interview is a method of counseling patient. We can use it in educating patient in different range, not only for smoking cessation, even in any type of health education. But today I will focus only on smoking cessation. As we learned in medical school that we usually give patient direct advice like exercise for 30 minutes, stop smoking, follow diet. But in motivational interview, we need to resist. This is right-hand reflex. This is called right-hand reflex. So what is motivational interview? It is a collaborative approach. It is a method, collaborative approach, in which we strengthen the patient on motivation of change. And we listen to the patient and we direct the patient to change through elicit the patient on himself about the change talk. There are several technical components, specific technical components when applying motivational interview. As I mentioned, we need to resisting the right-hand reflex, like we should not give the patient direct advice. We need to understand the patient on motivation. In case of smoking cessation, like to ask the patient, what motivates you to quit smoking? What triggers for quitting smoking? Who's in your family is supporting you? And one more thing is to listen with empathy. For example, in case of smoking counseling, like we tell the patient, I understand that quitting smoking could be overwhelming with your busy schedule. I understand that you've been used to smoke for long duration and you find joy with the smoking. So we should not be judgmental with the patient. We should show him that we are empathy and understand them. And another thing is to empower patient. Anything positive, we should encourage it or appreciate anything positive. So when using motivational interview and counseling patient, here are the skills that are fundamental to apply. First, open-ended question. So what does that mean? Like any question that does not end with yes or no. This question, we will evoke the patient talk. We will let the patient talk more about himself. For example, what brought you here today? Why you want to quit smoking? Who is in your family supporting you? An open-ended question, you will build a rapport with the patient. Patient will feel comfortable with you, talking with you. So you will build a relationship. And this is a first step. Another skill when using motivational interview is affirmation. That's mean appreciate anything positive. Here we empower the patient, acknowledge past strength. For example, even the minor things we appreciate it. Even if he come for your appointment, you said, I appreciate that you come here today. Even if he has a past attempt to quit, for example, if your patient said, I tried to quit for 2 weeks only, you don't be judgmental and say, oh, only 2 weeks. No, you appreciate that. So you tell him, it is great that you've been quitting for 2 weeks. So you can do it this time. In appreciation and affirmation, we does not mean that appraising the patient. It does not mean telling the patient, I know you can do it, you are a good person. No, you appreciate what is positive, what is going on well. Another skills, and it's very important when applying motivational interview, it is reflection. Reflection range between simple reflection to complex reflection. Simple reflection, just repeat what the patient said, repeat by his own word. Another type of reflection is rephrase. Like we change what the patient said, but a few words by using your own word, but reflect what he said. Another form which is complex, we can also engage the patient feelings. You show the patient that you understand his feeling, whether you feel frustrated, you cannot quit. I feel you show the patient that you really understand his emotion. So I want to use this type of reflection. The simple reflection, the direct one, you just repeat what the patient said. You use it if you hear a lot of sustained talk. If the patient argue a lot during counseling that he does not want to quit smoking, he is not ready, you just reflect what he said. While using the complex type of reflection, if you hear more about the change talk. Example of reflection. If the patient said during your counseling of smoking, I really want to quit smoking, but I find it so hard. And you hear it a lot in your clinical setting. So you tell the patient, it sounds that, for example, you want to quit, but you're facing some tough challenges. Here you let the patient hear again what he said and let him think deeply. And finally, summary. In summary, you summarize what happened during the whole consultation. You provide the whole picture. You just repeat what happened, what you said, and the patient, and it will show the patient that you really understand him. So I explained about the skills of motivation interview, the basic skills. Now I want to apply it on my case. My patient, he is Michael, 45 years old. He's married with 2 children. He's been smoking for 15 years with average 20 cigarettes per day. He has a previous attempt to quit smoking using nicotine patch, but relapsed within a month. His current situation, he's recently diagnosed with emphysema, and he is motivated to quit due to health concern, but feel ambivalent. Usually, this is the case we get in our clinical practice, and it's very common. So how to start with this patient? First, as I mentioned, the main skill is to start with as much as we have the open-ended question. So I will start with my patient to start building a rapport and to build a relationship with him. So I start with him, what brings you here today? How can I help you? So the patient here will express himself like, I want to quit smoking. Again, I will ask him another open-ended question. For example, in this case, why you want to quit smoking? So he will express himself. Another example of open-ended question, what health change you have noticed and concern? One example that who is you in your family you feel more comfortable talking with him regarding your smoking? Because he said he have kids, you can ask also, what do you like your kids to learn from you? Here, the patient will feel like he can express himself. He will feel respectful. He will talk more about himself, and he will feel confident with you and trust you. So in this case, my patient said that he has a family support, but he has concern regarding his health, and he wants to be a role model. This is the main motivation for him, that he wants to be a role model for his children. Again, I want to clarify our direction of counseling. I want to really know more about his motivation. So directly, I will ask him, I will identify what his motivation to quit smoking, what his triggers, and because he's recently diagnosed with emphysema, we will involve his diagnosis. I will ask him, how do you feel about your recent diagnosis? So as he mentioned that he has family support and he has concern because his family. So after I hear from him and asking a lot of open-ended question, I reflect back. So I told him, it seems like being a healthy parent is a big motivator for you. And then, so how you, again, I will move on in my consultation with more of open-ended question. Like I will tell him, how would you imagine your life if you, or how would your life improve if you quit smoking? So the patient expressed himself more. He said, I would have more energy. I will go finally hiking with my family. I wouldn't feel like I'm risking my health, and I will be a role model for my kids. So now I know my patient motivation. I know the triggers. I know that he has a concern regarding his health. I know that he has family support, and he wants to be a role model for his kids. Now we need to address the ambivalent, like in any normal case situation or when we counsel any type of patient, we will face this issue, the ambivalence. That part of the patient want to change and the other part of him feel like attached and he could not change. In this case of my patient, he said that he really want to quit smoking because of health issue. But on the other hand, he feel difficult to quit because the desire that smoking brings to him. So how to deal with ambivalent, as it's a very common issue in our practice? Again, with reflection. So we reflect and show the patient that we understand, we show empathy to them, and we should not be judgmental. So in this issue with ambivalence, we just reflect back. In this case, I'll tell him, I hear you. It is completely understandable to feel attached to something that's been parts of your life. But what do you think you might miss if you decide to quit? Here we'll give the chance to the patient to think deeply about the reason why he's not to quit smoking. Usually, another issue we face during counseling patient, the sustained talk. If your patient said, I don't want to quit smoking, I feel hard to quit smoking. So there is a strategy to deal with sustained talk. First, we should not ignore any type of sustained talk. On the other hand, we should not strengthen. One more thing, we should not argue a lot with the patient if he said, I don't want to quit smoking. Because if you argue a lot, it will strengthen the sustained talk and the patient will not feel comfortable with you. So most important to acknowledge the sustained talk to build a good relationship. So what's the strategy? There is a strategy to deal with the patient if you hear a lot of sustained talk. First, we have the amplified reflection, just reflection with no sarcasm. You will hear a lot in your clinical setting that the patients will say, I don't want to quit smoking. So you just only reflect back. An example of this, it sounds like quit smoking feels overwhelming and it's not acceptable to you right now. You really value the comfort, the enjoyment that smoking brings to you. You just reflect back. You should make sure your tone is not sarcastic. Otherwise, your patient will not feel comfortable with you. When you reflect back, your patient will hear again what he's saying and will let him think deep. Another strategy to respond to sustained talk, if the patient argue with a change, is double-sided reflection. For example, if he said, I know smoking is bad for my health, but I really enjoy it. And you hear a lot in your clinical setting. So you use the double-sided reflection. So on the one hand, you know the risk of health of smoking and you understand the negative impact. But on the other hand, you find the enjoyment of smoking. So this is a way of replying back to your patient. This is what let him think deeply. Most important thing when responding to sustained talk is emphasize the patient autonomy. The patient has a right to say his decision. You should tell the patient, I wonder what you decide. Give him words like, it's really up to you. Another way is reframing. What's that? What does that mean? For example, if he said, I don't know if I can quit smoking, you just reframe what he said. So it's quite challenge for you. You just reflect back and reframe. Another strategy, this is agreeing with the test. And this strategy, you acknowledge what the patient said, and then you add on something that encourage him to think deeply. So if the patient said, I just can't see how quitting would be worth it. I feel hard and I really enjoy smoking. So how you use this strategy? First, acknowledge what he said. So I completely understand. It is challenging for you. And then you add something or a question, let him think deeply. So what do you think? How would you imagine your life if you quit smoking? How would you think your health will be if you quit smoking? And what do you think about spending more quality time with your family? So this is another method. And last strategy is running head start. This strategy use it only if you don't hear any type of change talk. If all the consultation your patient argue, I don't want to quit smoking, I'm happy with the smoking, you use this strategy, but it's not advisable to use routinely. So in this strategy, you just summarize what patient said. You just, whatever happened during consultation, just repeat it back. And then ask your patient, what's the downside of not quitting? Let him talk, and then ask him, what's the advantage of changing? Here also, we'll let the patient express and listen and hear himself. So finally, when we use this motivational interview and our patient agree to change, we move to a plan. Also in the planning for quitting smoking, it should be collaborative between you and the patient. You should ask the patient, what do you think? What might be helpful for you? You don't give direct advice. If you want to give a direct advice in motivation interview, you should take you should ask the patient for permission. Would you mind if I advise you? I have some idea. You want to hear from me? Don't give the advice directly. We can consider different options like nicotine replacement to set a quit date. Even for setting a quit date, you ask the patient, let's think together what's a suitable date for you. And never to forget that during planning, it should be a measurable and realistic goal. Most important to follow up with the patient to identify if he has any motivation, any obstacles, whatever faced him. Also to encourage anything positive happened during his attempt. Finally, during last and our consultation, encouragement is very good. So I tell my patient, it's great that you are taking steps to consider quitting. Changes takes time, and it's okay to face challenges along the way. So the takeaway message from motivation interview, we need to understand it's a collaborative approach between you and the patient. You need to build a rapport, ask as much you want the open-ended question, show the patient your empathy, reflect back, show that you understand his feelings, explore his ambivalent. As we said, it is common that he want to quit and then not to quit. Explore both sides. Change talk, express more with the patient, set the goal together and should be a realistic goal, and then empower patient by recognizing his strength and any past good experience. Here is my reference. Thank you.
Thank you so much, Muna. This is the second time I hear you talking about motivational interview, and each time I find it, you make it so clear and understandable. But for the reference, just for you to know that all this webinar is recorded and will be in the Lifestyle Medicine SIG site, so you will be able to follow these presentations again, because maybe sometimes for people who face this for the first time, it might be a little complicated. But if you follow this like slide by slide, it makes it very simple, very coherent, and you can really take this home to your clinic and use it. So thank you very much, Muna. And and you please stay with us, because I hope I can see that there are some questions. So at the end of the presentations, we'll have time for people also to ask more questions in the Q&A, and for all the presenters to relate to them. So Tehila, is everything in order now?
Yes, you know, you
Good.
plan and you have everything set, and then life happens.
So take two, and you're invited to discuss Mediterranean diet, please.
Thank you. Okay, so good evening to everyone, and thank you for joining our webinar. I'm going to talk about the nutrition pillar of lifestyle medicine and how you do nutrition counseling. I'll give tools and tips, and I'll emphasize the Mediterranean diet, and also talk about some EBM. Okay. And I just always start my presentation by pointing out that I don't know about the participants, but I received 1 hour about nutrition studying 7 years of medicine. And I think it's a pity, and it's really important. So I just went about studying it on my own accord, listening into lectures, going to conferences, reading a lot about nutrition. And that's why I also want to, I took it upon myself to teach nutrition to family doctors. And one of the reasons it's so important to learn about nutrition, because maybe you ask yourself, but we have dietitians, why don't we just send them to dietitians? Why do we need to know about nutrition? So first of all, about 30% plus minus of the people you send to dietitians, at least that's the statistics in Israel, only 30% will get to the dietitian at the end. So maybe it's because of the time waiting for appointment, which can take like up to 3 months by us, or they just are not that into it, or so you should know yourself how to talk about the diet, different kinds of nutrition with your patients. And also they come to you with lots of questions. Which diet, doctor, which diet should I use? I want to, mostly the popular diets are, I want to lose weight. Which do you recommend? Because there are lots of diets on the web. Or which diet should I follow for my high cholesterol or high blood pressure? So we should know some basic knowledge about nutrition to give our the right advice for our patients. Okay, so that's the reason I'm going to talk about the nutrition. Okay, so I'm also going to give a case presentation, which will follow my presentation throughout. So Sarah is 45 years old, married, mother of 3. An annual checkup revealed a glucose level of 116 and hemoglobin A1C later followed with a result of 6. LDL and triglycerides were 140 and 200 respectively, HDL 65. Physical activity is mostly running after children. The nutrition isn't very healthy, as 1 meal a day at work, anything that they order in. At home, it consists of grabbing food that's left over from her children between taking care of them and home chores. So I just want you to think about how would you counsel her? What would you emphasize? Okay, so I want to talk about the Mediterranean diet, especially. As you see the Mediterranean pyramid on the right. So the Mediterranean diet focuses on quality rather than a single nutrient or food group. The Mediterranean diet is actually based on food patterns typical of Crete, most of the rest of Greece and southern Italy. In the early 1960s, adult life expectancy was among the highest in the world in these regions. In rates of coronary heart disease and certain cancers and other diet-related chronic diseases were among the lowest. So the Mediterranean diet is from the Mediterranean region. The diet features simple plant-based cooking and with the majority of each meal focusing on fruit and vegetables, which have a lot of antioxidants, a lot of vitamins, whole grains, beans, and seeds with a few nuts and heavy emphasis on extra virgin olive oil. Eating healthy, oily fish with, which are packed with omega-3 fatty acids is encouraged, while eggs, dairy, and poultry are eaten in much smaller portions than in the traditional Western diet. And red meat, for example, is recommended not more than once a week. Social interactions during meals and exercise are basic cornerstones of the Mediterranean style of eating, and lifestyle changes that are part of the diet include eating with friends and family, socializing over meals, mindful eating, favorite foods, as well as mindful movement and exercise. So as you see, it's a whole Mediterranean lifestyle, not a Mediterranean diet. So the Mediterranean diet is not only a way to eat, it's a lifestyle, as we said. And we have many organizations that emphasize how important it is to follow a Mediterranean diet. So for example, the American Diabetes Association guidelines in 2021 already emphasized using the Mediterranean lifestyle eating pattern to improve both glucose and lipid metabolism, thus minimizing individuals' cardiovascular risk. Overall potential mechanisms underlying the beneficial effects you can see in one of the papers here on the right Effects of Mediterranean include improvement in oxidative stress, inflammation, thrombosis, insulin sensitivity, lipid profile, endothelial dysfunction, and gut microbiome. So really, it's very good for you. Okay, so the Mediterranean lifestyle topped the scale as the best diet overall. So it's not only healthy. I'll show you it's good in many ways. That's in the annual best diet rank in the US, a survey that's well known and taken seriously. It's ranked already 7 or 8 years consecutively. It also ranked first in the categories of best diets for healthy eating, easiest diet to follow, which is important because you can give a person a diet, but if it's not easy to follow, you won't do it. Best diet for diabetes, best plant-based diet, so it's also for vegetarians, for example, and best heart healthy diet. So it's not so much as what they eat, which is beneficial and anti-inflammatory, it's in how they eat it too. So numerous studies have found the Mediterranean diet can help weight loss and reduce the risk of high cholesterol, lower LDL and triglycerides, and raising HDL, CVA and CVD, diabetes, and improve blood sugar control for those who already have diabetes, for example. Not only prevent diabetes, but also treat diabetes. Dementia even, and memory loss, depression, all have been linked to lowering the risk of also breast cancer, colon and prostate cancer, which is really amazing. So how it all started, a few more slides about the EBM, and then I'll go to the tools and tips. So it started with the 7 different countries research, which led by Keith. He was actually a physiologist in Minnesota. In the 1950s, he brought together researchers from all over the world. As you see, it's USA, Finland, Yugoslavia, Greece, Japan, Italy, Netherlands, to researchers from all over the world. It became a collective effort to study the joint questions about heart and vascular disease. That's how it started, among countries having very traditional eating patterns and lifestyles. So the 7-country study suggested that the risk and rates of heart attack and stroke, both at the population level and at the individual level, correlated directly and independently to the level of total serum cholesterol. And then they went on looking into why they have different levels of cholesterol. And then they got to the diet patterns. They found also a reduction in cancer, and really they decided to take it more seriously and look into the diet, and they found that, as you see here in the graph, that Crete had the best overall cause mortality, lowest all-cause mortality. So they looked into the Mediterranean diet, which they have in Crete. Then afterwards, we had the last study, came after that. And by the way, they went on studying the different factors that they in the research for over 40 years. So it's a really longitudinal study. And then we have the Predine study that was done in Spain from 2003 to 2011. And they also showed that it was the first randomized clinical trial designed to evaluate the beneficial effects of the Mediterranean diet in primary prevention of cardiovascular disease. And they even found that they stopped the research in the middle because there was a difference in 30% over 5 years from the groups that were assigned to Mediterranean diet, or with olive oil or with nuts, compared to a diet that just were asked to have a diet that's low in fat, but they let them eat whatever they want. And also the Mediterranean diet, they were unrestricted to eat it as they want and the amount that they wanted. And there were, they found that they had a lower risk of major cardiovascular events significantly. Okay, and last research I just want to mention shortly, the umbrella review showed the Mediterranean diet reduces the risk of cardiovascular disease, diabetes, cancer incidence, neurodegenerative diseases, and overall mortality. And this was a 13 meta-analysis of 13 observative studies cohorts and 16 meta-analysis of RCTs. I just, for example, gave the cohort forest plot. Sorry. Okay, so back to Sarah and tools we can use in the clinic. So for example, we can use the SMART tool, which is specific, measurable, attainable, realistic, time sensitive. It's a method used for creating goals that give you a sense of direction and helps you define, organize, and reach your goals. So I recommend to talk with your patients about setting SMART goals. It can be sticking to a Mediterranean regime, starting to exercise. For example, eat more vegetables and fruit, drink more water, stop eating junk food late at night, eat more home-cooked meals, eat less sugar. You should speak to your patients and ask them what they prefer to do, what they think they're interested to do, or they think that's more realistic for them. I can give you an example. Setting SMART goals can be, for example, suggest a goal of walking 30 minutes a day, 3 days a week for 2 months, okay? Or another one will be to replace soda with water every day for the next month, rather than a goal to give up all sugar. And that I'll talk about soon, about setting small steps. Don't change the whole diet, but start small steps, and then there's more chance that they will stick to that and manage to make the change. So Sarah decided to, so I spoke to her and I asked her what she would like to change and how it's important for her, and what are the pros and cons to change her lifestyle, specifically her diet. I spoke to her about the Mediterranean diet. I showed her the pyramid. You can download it from Google, type it and give it, for example, to your patients. So she decided to focus on eating more home-cooked meals, for example. That was her SMART goal. So plan at least 2 home-cooked meals per week for the next month. Pack your lunch for work. So instead of ordering in, more like junk food, so at least 2 nights she'll pack her lunchbox for the next day at work. So she'll have healthy cooked meals for at work. Eat at least 1 meal each day, sitting down and without distractions for a week. And after a month, you can add next goal. So they come back to you, ask them to come back for a follow-up a month later. And then you can adjust your SMART goals for, like, plan at least 3 home-cooked meals per week for the next month. Have fish 3 times a week for the next 8 weeks. Consume 5 servings of fruits and vegetables 5 days a week for a month, okay? So these are examples. Another example, you can have pamphlets or even a picture up on the wall they can ask you about. It catches the eye, it's nice and colorful. This is an example of a pamphlet we made especially for WONCA Dublin for our Symposium Day of the Lifestyle SIG, the 6 pillars of lifestyle medicine. And you can, if you want, you can send maybe an email, they can send us an email, Lilach, and we can send you the pamphlet you can use in your clinics.
Maybe we can give it as a present to all the people who showed up. We can send them.
That's a great idea. So we got really good, people really got excited about the pamphlet and asked for it. So we would be very happy to give it to you. So you can just give it out to your patients that will have something to take home, put it on the fridge so they see it every day. There's more of a chance, the higher chance that they'll actually read it and start going by it. And then I wanted to show you that there's an option that you can also make your own pamphlets or pages with recommendations and give it to them. Or points that you can talk to them about. So for example, these are really short points that it's got to do with the Mediterranean lifestyle pyramid. As you saw, that's got to do with all your healthy lifestyle almost. So for example, how to choose healthy ingredients and provide healthier cooking methods. So read the ingredients on the product. A lot of people don't read the ingredients. Prefer the ones without preservatives, food coloring, added unnatural flavoring, saturated or trans fats. Use less sugar and less salt. If you can't make sense of the ingredients or make it at home, don't eat it. Prefer sea fish over meat. Have fish 2-3 times a week. Make your own dressing in pastas. You can make your own ketchup at home. Did you know that? Or salad dressing. And they have a lot less sugar and salt and for sure preservatives and a better olive oil than the oils they use in the bought salad dressings. Use healthier food preparing methods like freshly cut or cooked, baked or steamed than frying foods, which isn't healthy. If you want something sweet, have a fruit, preferably with a nut. You know that if you have sugar, preferably fruit, and you have it with something that has a like a nut, like fat and protein, healthy, your blood sugar will rise slower. So that's a good tip. Prepare the whole packet. If you're cooking your packet of legumes, prepare the whole packet already. Use some of it in your salad or in as a side dish or in a soup, and then you have the rest of the packet you can freeze and just pour it into, use it for the rest of the week. You have it already cooked, so it's more convenient. And as I said, little steps. Steps are sometimes, or change is frightening. We know that psychologically. So if you make it, you break things down into small steps, so the brain will less be fear and less feel that you're confronted, and to be easier to accept and start making the change, small changes. Go far, and small steps make a big difference. So availability, have vegetables, fruit, legumes, fresh nuts and seeds in the kitchen, in sight. If you have it in sight, there's also, you eat more fruit and vegetables, and also your children will. So the change that you make is a good example for your whole family. You can tell them that. Have more than 5 portions of vegetables and fruit a day in different colors. Have home-cooked meals most of the week. Have extra virgin olive oil. Limit processed foods. Add legumes to your meals every day. Drink water abundantly instead of soda or soft drinks, and move as much as possible. So these are recommendations, really, that are like global, that many lifestyle medicine groups use. And it's also evidence-based. And getting back to Sarah, so 3 months later, she's more active, walking 3 minutes 3 times a week, eating a Mediterranean diet 4 times, cooked meals 4 times a week, and taking leftovers to eat at work, drinking 8 glasses of water a day. For example, in summer, you can also drink 10 glasses a day, but it's between 2 and 3 liters, depending on your weight or how old you are. She lost 3 kilos, even unintentionally, feeling good and motivated. Her blood test really improved. From glucose 116, she went down to 100, and now it's even better. Hemoglobin A1C went down to 5.6. It also improved since then. Cholesterol, LDL from 140 to 106, triglyceride from 200 to 137, and HDL 63. So just a question, what would be the next SMART goal, for example? And if you don't have time or resources, this is also evidence-based, what to say to a patient in 30 seconds, because we're all the time stressed of time, and family doctors don't have a lot of time. So you can just give these 3 points. Increasing vegetables and fruit intake can reverse the rising trend in diet-related diseases. Eating shared family meals prepared at home leads to better food choices and lower calories, and promote Mediterranean diet. So remember, keeping a healthy lifestyle can prevent, treat, and often reverse chronic diseases. So thank you very much.
Thank you so much, Tehila. I think it was eye-opening for many people. I know that people knows Mediterranean diet, but to hear it like step by step and the recommendation like this, I think it helps a lot. And using a SMART goal, it's a good idea. And I hope you will remember that. I just remember while you were talking that I was standing in the supermarket, and a young girl asked her father, "Can you buy me this chewing gum?" So he told her, "If you can tell me what is in this chewing gum, I will buy it to you." And of course, she couldn't say, because things that are all processed food, you cannot tell what's in them, and
Right.
it's better not to buy them.
Yeah, even your table salt, you don't know that it's not only salt in there.
That's further. Okay. Josie, what are you showing us?
I'm trying to get my slides.
Oh, okay. Okay, so let me just present quickly Professor Joyce Kenkre. She's an Emeritus Professor of Primary Care from the University of South Wales and the chair of the WONCA Europe Special Interest Group for Social Prescribing and Community Orientation. And she will describe for people who less familiar with social prescribing what it is and how it can work for the sake of the patient and for their lifestyle as well. So please, Joyce.
I'm just wondering about the time. That's the only thing. I'll try and be as quick as possible. And it's just thinking that social prescribing really can be complementary to lifestyle medicine in that it's creating the opportunity for healthy options, and the social prescribing model seems to offer a promising strategy for advancing lifestyle medicine. And social prescribing is about supporting people with social, emotional, practical needs through non-clinical community support to improve their mental health, physical well-being, by giving them time to focus on what matters to them and help them take greater control of their life. And it's just saying that, you know, social prescribing can impact on social determinants of health. So thinking about social economic status, education, the neighbourhood and physical environment, employment, social support networks, access to healthcare. And really what I want to do is really think about providing the evidence that actually social prescribing works. GPs have been referring to voluntary organisations for a long time. And HomeStart UK, founded in 1973, has over 300 branches. And over 18 months, information was collected on 33,920 families and 76,031 children, supported by 15,000 volunteers. And it's the positive evaluation of parent-child health and well-being. So just going over some of the family circumstances on referral, the majority, 34%, were living alone. 379 were fathers living alone with their children. And it's just covering the breadth of issues: mental health, postnatal depression, domestic abuse, learning disabilities. But also thinking about, you know, when asking, thinking about the needs of the families. So when they go to refer them to HomeStart, they ask them about their needs, their parenting skills, managing the child's behaviour, child development, parenting well-being, coping with their own physical and mental health, and the feeling of isolation and self-esteem, but also about the children's well-being, physical and mental, and the family management. So thinking about a whole range of issues: managing the household budget, day-to-day running of the household, stress with conflict within the family, coping with multiple children under 5, and use of services. So the type of support supplied by HomeStart was really thinking about practical support, activities with the children, and emotional support and use of services. But it's just enabling them to visit the primary healthcare team, mother and baby clinic, but also it's the way that they can do it. They can actually take them there and introduce them, or they can look after the children so the parent can go to the services, and really trying to enable them to engage with the different organisations such as step counselling and the mother and toddler group. But actually looking at the data and the domains of change over time, thinking about what I mentioned about the different areas of need, they demonstrated change, significant change over time, particularly in parenting well-being, family management, parenting skills, and also the children's well-being. But also thinking about the benefits to volunteering. The volunteers when they start off. And a lot of these volunteers actually are people that at one time were helped themselves. So they are actually trained in policy and procedures in home visiting, safeguarding, child development, domestic abuse. And actually that gives them the opportunity to participate in community and social events, support information networks, actively seeking employment, working with voluntary other organisations. But what does it do for the volunteer themselves as well? It gives them self-confidence, sense of usefulness, awareness of effect on others, willing to try new things, confidence in their own identity, and looking forward to new ideas. So another initiative for young parents and children was Our Place. And actually Our Place came out of the, what happened was there was a huge randomized control on teenage pregnancy in England. And some young teenage mums from Wales actually advised on that study on everything from how to ask questions, the documentation, the design of posters and leaflets, and also IT systems. So it actually then highlighted the need for a place, Our Place, for young parents, a drop-in centre. And it was for young parents with young children, those that are isolated with low self-esteem, young parents that felt stressed, and young parents that needed help with parenting skills. And how the sessions work is the young mums actually worked out themselves the information that they needed to actually address some of their issues. So they actually helped design the programme. And each week they had a learning activity for the parents, a joint activity with the parents and children, and free time for refreshments and socialising and play. And the initial programme was actually financed by a housing association. And so what they covered a whole range of issues: childhood illnesses, weaning, general nutrition, dental health, health and safety in the home. So, but what have the young mums done themselves after participating in this? They actually organised toys for the group. They created a closed Facebook account whereby the young parents and the team are able to contact each other. So if there was nappies on sale on a particular supermarket, they all knew about it. If the baby food was on offer, they all knew about it. So they actually let people know, and the group know, activities and also offers being presented. But they also organised fundraising events to charity for cancer and other issues. They designed all the advertising materials, helped another group set up in another town, but also helped older people grow up, use technology, but also living healthier lifestyles themselves from the information they gathered, and also advising on other research projects. And a recent group that's been set up by one of the young mums is a running group, but also a running group for all age groups, and it's called Blister Sisters. So it's really thinking about what just a small initiative can make a difference to so many lives. But what has Our Place meant to the young mums? They made new friends, they're more confident, they're able to have a healthier lifestyle choices, nurture better relationships, confident in their own parenting skills, and now able to build healthy, independent, happy lives. And many gone into gaining employment, whereas they would have normally been on state benefits. But thinking about comments from the parent-child relationship, we talk all the time, we dance, we sing, we make more time for bedtime stories, cook together, clean up, toys, go to the park. We love singing, dancing together. We talk all the time, explaining about things in the supermarket, on the bus, out for a walk, and in the bath. So just to say that the social prescribing and community orientation group has been going for over a year. And in the last year, we applied for 3 European grants, and surprisingly, we won all 3 of the grants. The social prescribing to promote and improve access to healthcare services for people in vulnerable situations in Europe was a Horizon bid, and it looks at different groups and LGBTIQ groups, refugees, first generation immigrants, old people living alone. So that's going forward, and that was led by Wolfram Hermann in Germany, and there's 20 partners participating. Another project that's being funded is for the Erasmus Plus program, and it's called Space Prescribing and Civic Engagement, which aims to bring together social prescribing and volunteering to create an environment to an approach that supports the health and well-being of people, health and rehabilitation needs, recovering from cancer. And that's led by Gabriela Civico and Juan Mendev from Spain. The final project that's been funded is Recipes for Successful Approaches to Social Prescribing in Primary Care, a Delphi study on best practices in Europe. And if you want to participate that, if you know anything about social prescribing, please contact Ferdinando Prizzoli. The funding that we've gained for this research to take forward social prescribing is over 7.3 million euros. So in conclusion, we think we need to rethink how we can improve well-being in our communities, focusing and harnessing and strengthening the power within the communities rather than viewing them as bundles of needs. And social relationships have a value. Social connectedness has a profound influence on well-being on issues such as long-term illness, unemployment, and being a parent. Okay, so the contact details. So I've just tried to be a whistle-stop tour because we're short of time. Okay.
Thank you so much, Joyce. Really, you made it quick but very understandable, and I hope people will grasp the idea of social prescribing as really a great tool for family practice and to improve lifestyle and life of people they treat. So I want to thank all the presenters, and we have like 2 questions I think we should answer if this is possible. So one is to you, Tehila, about, can you see the Q&A? Yeah, so the question was, should we plan an adaptation of the Mediterranean diet to elderly patients? Just unmute yourself. Yeah, great.
Good question. So I didn't get a chance to actually say that in elderly, we are worried about a problem of losing muscle, right? So we can emphasize having more protein and healthy fat and exercising, of course, except for the eating Mediterranean diet. It's not a calorie-based diet. We don't count calories, but obviously we can look at the person. If it's got, the goal is to lose weight, so we can restrict the Mediterranean diet to, like, for example, filling up your plate once and not, so restricting the amount of the Mediterranean diet, what you eat. And for elderly or people that are thin and they want to actually put on weight or put on muscle, so they should at the same time emphasize more protein, healthy protein. It doesn't have to be like you saw from animal. It can be legumes, nuts, and emphasize fish, oily fish from the sea, and exercise. So that's what I would say. That's what I would recommend.
Yeah, thank you. Thank you. It's really important because our patients are getting older and we need to know how to recommend them properly.
Prevent and treat sarcopenia. Mm-hmm.
Yeah, Yeah. Thank you, Tehila. And a question for you, Joyce. I can see about, can you see that rural areas experience higher rates of obesity and overweight, and how this issue can be addressed? I don't know if it's just for you or for everybody.
Okay. So there are different diets, as you know. I mean, I didn't go through the different diets. I have like 2.5 hours of just about nutrition for our residents. So I emphasize in this lecture, because we had to keep it short, only the Mediterranean diet. But in general, if anybody asks you about a specific diet, also to lose weight, to be healthier, you should just choose one diet that really answers all and improves everything. That's the Mediterranean diet. So I would emphasize the Mediterranean diet, and obviously other pillars of the lifestyle medicine, like sleeping well, drinking enough water, and obviously exercising. So I would teach them about the Mediterranean diet and SMART goals with a motivational interview. Yeah, that's what I would do.
Great, thank you. So we are almost at the end of this webinar, and I want to thank again all the presenters. I want to thank you for joining. I want to thank WONCA for supporting, WONCA team for supporting this this webinar. They are working a lot behind the scene, and they are helping us to really prepare to this activity. And I think these activities are very, very important, because we bring information and things like practical tools and some education. And also we will send the pamphlets, and you can watch this again if you're interested to learn more about the things that we just presented. So I want to thank everybody for joining, and WONCA for supporting us. And I would love to have you all as members of our SIG. So please join the movement. You can join through the Lifestyle Medicine Special Interest Group site. There is like a free membership attendance. So please, and hope to see you all in Lisbon.
And also social prescribing. SIG.
Yeah.
If you want to join social prescribing, please join.
Yeah, we will send all the links, so you will be able to join us. So thank you. Have a great evening and take care. Bye.
Bye.